Mike Browning, welcome. I'm Jim Alpus, Leadership Programs Director for the Health Leaders Exchange, and we're live at the opening reception for the CFO Exchange. Mike, thanks for coming down.
Oh, you're welcome. Thanks for inviting me.
Great to see you again.
It's good to see you as well.
Let's chat about what's going on at OhioHeath. The industry is pretty well known right now. Operating margins are a challenge across the industry. How are things at OhioHeath? What are you facing these days?
Well, Jim, we've had all the challenges everyone else has had: labor, supply chain, all the things. COVID really taught us a lot in how to be more proactive and more aggressive. And so I'll always remember, I think day 2 of when we sent everybody home from COVID, we already started on the back to work plan and trying to be very proactive. So we've done a really good job of forecasting and projecting where we need to be and then adjusting as we needed to. So when COVID started to lighten up and we needed to have additional volume, we were prepared for that. So our margins are still strong. So our pre-COVID margins were in the 5% range. Our margins this year through 8 months are over 5%. So we've been able to hold it. But we're also dealing with the increase of labor. It's there, and we're paying for it. So we're making adjustments in other areas of our business, whether it's supply chain or other purchase services, all the things we have to adjust to maintain the margin.
Well, y'all are a bit of an exception if your margins are still at pre-COVID levels.
Yes.
Across the industry, that's not real common, as you know. Tell me a little bit about, what are you facing in terms of competition in the market? I think that's some of what we want to talk about. We're seeing all sorts of non-hospital providers in markets across the country, whether they're from big players, Amazon, CVS, United Healthcare. What's competition look like in your market?
Columbus is a great market. It's a great market to live in. It's a great market to be part of. Our competition is Ohio State University as well as Mount Carmel, which is owned by Trinity. So you have a national player and then you have a state player that's there. We kind of kid that Ohio State is funded by the state, so they're able to do a lot of things that other organizations can't do. But the competition makes us better. And Columbus is a market that a lot of the disruptors like because it's a fairly profitable market. It's good for them to come in and learn and do things. So we have all the disruptors in our market as well. And as difficult as it is, we do think they do make us a little better. And we're actually partnering with some of them. ChinMed's a good example for us. ChinMed will typically go into a market and really manage the elderly population. We have a partnership with them. We're their provider of care. We've been working with them for about 3 years. It's been a win for the Chin family as well as a win for OhioHeath. And when the disruptors come in, we try to partner the best we can.
It's funny. I actually heard Columbus is a test market for a lot of industries. I was talking to a restaurant owner in Nashville, and he was saying their first franchise was in Columbus for that reason. For whatever reason, their companies across America just love to test Columbus. I guess it hits that sweet spot of demographics and all the things that you want to see.
It's a really neat city because it's a state capital, and also you have Ohio State University, but you have the same challenges that Columbus, all cities do. There's a big investment downtown, which helps. We're partnering with some of the universities to try and make sure we have the talent we need, and so there's a real collaboration amongst the city and the county. And we're in central Ohio outside Columbus, and so we have a lot of facilities outside there as well, and those communities are helping as well.
Are you seeing a lot of competition in the physician space? There's obviously we talk about some of the big players. The biggest medical group in the country today is owned by United Healthcare.
Yes.
70,000 physicians are part of Optum right now. And that's just one of them. You're seeing physicians being acquired by private equity all over the country. Mostly it's concentrated in ambulatory care, primary care. Are you facing that type of competition for your physician space?
We have, and OhioHeath is the preferred physician organization. Mm-hmm. Physicians train there, they like OhioHeath, and they like to be part of it. But what's happened over the years is they don't always want to be employed. And so many of them want different models, and so we've had to adjust to that. We will add about 100 to 200 physicians per year, and we have a very thorough, we spend a lot of time on our physician strategy. It's been a real benefit to the organization as a whole, so we take it very seriously. But in the past couple of years, we've identified that we don't have all the models the doctors want. So They may go to a United or Optum, they may go to other models that are out there. So we recently partnered with a company called Privia. And Privia is an organization that has had a lot of success, or they're a new company, but they've had a lot of success, and they're going to give those models to those physicians they need and help them run their practice the way they want, but still have independence, and they'll have the alignment with OhioHeath, which we think will be really positive.
But do you think you have to have those every model? I mean, we're getting to the point with physicians where they have choices. I mean, if they choose to want to go work in that type of corporate medical setting, venture capital owned or private equity owned, or owned by a payer, vertically aligned, they have that choice. But if they want to work at a health system where they're going to get different types of cases, they're going to maybe have more of a community tie, I mean, how do you position OhioHeath to make sure you're still that choice?
Yeah, that's a great question, because of the fact that you can't be everything to everyone.
No.
And you have to figure out what you do well and then what you don't do well. And for us, we figured out we didn't do certain parts of physician practice management as well as somebody outside, so that's why we went to Privia. So you can augment your inabilities to do things with certain groups, but sometimes you have to walk away. Because what we try to do, I think where we fail in healthcare is we do try to be everything to everyone.
Right.
And what we're learning, and what's come out of COVID, is that there are some things we don't do well. So you'll see in the near future, you'll see some partnerships that we'll be part of. Parts of our business will partner with other parties who can do it better than us. And the physician side of it was Privia, and that's not going to answer all of the problems that are out there. So there will be some groups who maybe don't select us because we're not able to adapt to it, because we don't want to get into a model that we don't do well.
With all the, I mean, you have an active market, and as we've said, Ohio, Columbus is an innovative area. It's great state university, a lot of innovation around healthcare in and around Columbus. Workforce still is issue number one. We've talked about physicians, but then you get into nurses, IT talent, which again is there's a platform for it in Columbus. How are you competing in those spaces, particularly with nurse labor costs have not gone down that much?
Yeah, we've resolved the fact we're going to have agencies, and that's where we've had to make adjustments in our income statement and other areas to be able to offset it. Doesn't mean we're happy with it. We think traveling nurses, while they're really competent and do a nice job, they don't always have the same patient sense of the OhioHeath nurses that are there. So we want to get nurses in and other specialties in that would be there a while. The tenure of OhioHeath employees is pretty long. Once you get there, they do like it. But we're challenged in facilities. We're challenged in all the areas that everybody's out there. So that's where we're working with some of the local colleges and universities to start to improve that pipeline, even getting into the high schools to do it. That's a long-term strategy. But the short term, we're trying to be the employer of choice. We've been top 100 places to work for a number of years. Our CEO takes that very seriously. He's very focused on making sure people have a good place to work and the things that we do and how they're treated. But some of it's the fact of healthcare has changed.
Right.
The patients are different now than they've been. There's a lot of anger, some of the patients.
And they're sicker.
They're sicker, and the fact that you have a little more combative patient family members that make it disadvantageous for certain people to work. So we're trying to address those issues as well. So we're trying to really get to the root cause of what's causing people to leave, to fix it, and it's not all about money. Money's important, but there are other aspects and how we can target those. But improving the pipeline's an important part for us. We're willing to make some large investments to do that because we do believe it's important.
Are you working with your nurse leadership to look at, not just nurse staffing? I mean, there's obviously you've got regulatory issues around nurse staffing, but the practice of nursing, using different types of providers in different roles. The saying is to maximize the top of their license. So, nurses aren't doing things that they don't need to be doing. That's been something that's going on for healthcare for years, but are you accelerating that, or are you finding more value in that?
You're having to, because you're having to make sure the nurses have the support they need and they can provide the care to the patients, and you're having to augment some of the things that they've done historically with other people, and they can work atop a license. And I do believe that's important. We have brought in some LPNs, as many have done, to try to bring more people into the situation, but we're still keeping our nurse-to-patient ratios the same. I don't think those have been adjusted much. It's just trying to make sure we have the right people there. We're doing some things where you probably heard of sitters, that you have to have sitters with patients. We're doing that remotely now, so trying to manage those resources a little bit better, how we do it, and taking some of those people who are sitters and putting them on the floor to be able to help the nurses provide care.
Are you looking to supplement that value with either through technology, workflow, or other solutions? We've talked in the past about technology that's very patient-facing, patient experience related, but are you looking at solutions and technology that are going to add to that FTE value, that are going to take some of the burden off of nurses and others in the clinical stream?
Absolutely, and that's something there's something to fix everything.
Yeah.
If you talk to the vendors out there, they have a solution for everything. It's weeding through what the right solution is for us and trying to make sure we get the right solution that fits the problem we have today. It was national news that we did outsource IT, and so that was effective January 1, and we did it intentionally because we can get more resources.
Yeah.
The ability to hire IT people is very difficult, and so by having a pool of talent that's international, we can actually get a lot more work done and be able to speed it up, whereas we were constrained by the resources we had before. So some people thought it was a money grab. It was not a money grab. We'll likely spend more money in IT in the long term, but we'll get a lot more done, probably as good or better and quicker.
It was IT and revenue cycle, correct?
Revenue cycle is a small piece. We
Right.
still employ about 1,500 people in rev cycle, but we've done outsourcing in rev cycle 3 different times. It's a few hundred people. We only do it where it was appropriate, where you could really get value. And example would be coders. It's hard to find good coders, and when you can outsource that work, and there are a lot of coders that are out there that helped us manage the workload.
But isn't that part of the recognition of what your core talent is as the health system? It's taking care of patients and not running an IT enterprise. I mean, y'all aren't the only health system that's walking through that decision. I mean, do you expect others, I can't speak for others, but do you expect we'll see more of that cascade as health systems sort of retreat to what their core value and core experience is?
Yeah, I think as leaders in healthcare, you have to look at it. You have to analyze to see if it fits you. So our example was, when we did IT, we were looking to outsource IT and rev cycle together.
Right.
When we did the rev cycle analysis, the juice wasn't worth the squeeze. And for us, we could do it as good or better than what we were finding in the market. We found a good partner to do what we needed to get done, but we went into it thinking we would do it, and once we went through all the data, figured out it wasn't the best thing. And that's where you get to, even, we're providers of services and we do it really well, but there's certain parts that we don't do as well, and that's where partnership comes in as well. We want to be partners with people who can do it better than us. We don't want to sell it and get away from it.
Right.
We want to have a seat at the table for the discussions to make sure our patients are taken care of, but there are people out there who can manage businesses in a better way. I always pick on food service, Sodexo and Morrison's and all those do a really good job at it. They do it better than we do it.
Yeah.
And so there are always those groups out there that have those niche services that can do it better, and we're looking at all those angles because the future of healthcare is going to be quite different than it is today.
I've been covering this industry for a couple decades. You've been a veteran healthcare leader. We know what has happened in outsourcing in the past. You outsource something, then you kind of miss that control after a couple of years, and then sure enough, you're pulling it back in. How did you put in the steps to make sure that there's some longevity to it this time?
There is, and it's making it where it's not, it's number one, you've got your service level agreements in place where things have to be done. You want to make sure you pick the right vendors and the right groups are going to partner with you, but also not making it easy to get rid of, to bring it back, because that's an easy choice to make, especially if you have different change in leadership. They may want to come in and have a splash to do that. So it won't be easy for us to bring IT back in totality, but we still believe it's the right strategy long term for us. Things may change in 3 years, and you always have to have that door open to be able to do that if things do change. But for us, we felt that with our growth strategy where we are and all the work on the table, we had to have more resources than we felt we could get.
How do the next few years look? It's hard to, I was talking the other day about what would a health system 5-year strategic plan have looked like in 2019? What would you do? But at the same time, how do you see your market? What are some of the areas you think are ripe to invest in? What is the outlook at the executive level for OhioHeath?
Well, we've always looked at our market as being Ohio. We're OhioHeath. And so what we're looking to the future is it may be outside Ohio, but we're doing a couple things. We think it's really bright for us as an opportunity. Intel's building a new facility in Columbus that'll create about 3,000 jobs. There's a lot of spin-off to that will help. So our market will continue to grow, and figuring out where we want to be, both inpatient and ambulatory, is important to us. We just recently announced a $1 billion capital investment, about $400 million into our downtown facility. While some people are leaving downtown, we're investing in downtown. We believe it's important. And we're also building a women's hospital on our Riverside campus to be able to do that. And we have other projects that will be coming out, because we do believe the future is bright for Columbus, for the markets we serve, but also for Ohio. We just acquired 2 new hospitals, one on the east side of the state and one on the west side of the state, and it's outside our traditional market. And so we're looking for partners in those markets to work with us as well, so that we can develop relationships, not partners of acquisition,
sure,
not mergers, but starting to work with other people that are in those border states to see if there are any synergies between the 2 organizations.
Well, Mike, thanks for your time. Thanks for coming down. I think the CFO Exchange, our members are going to want to hear about this 5% margin that you're able to maintain. I appreciate you sharing your insight. And again, thanks for coming. Thanks for
inviting me.
These
are always great events.
Mike, thanks.
Thanks, Joe.